Part 6 of care of the high-risk newborn is going to address hyperbilirubinemia, which is a very common occurrence, and it can occur in the term baby as well as the preterm. Newborns are born with a very high hematocrit, and you know that bilirubin is a byproduct of hemoglobin. So when the red cells break open, bilirubin levels go up. In addition, the newborn's liver is immature. It's not able to excrete bilirubin as efficiently as it will be able to in a 2-week period of time. So as a result, the bili levels go up in the blood. The reason we worry about bilirubin is because when it goes too high, the baby develops a condition called kernicterus, and this can lead to permanent mental retardation, developmental delay, and if it goes very, very high, it can lead to death. So the factors that are contributing to hyperbili is simply that they have a high hematocrit immediately after birth. The red cells begin to break down within the first 24 hours of their birth, and it peaks between 3 to 4 days in a full-term baby, but in a preterm baby, it's going to take almost a week. Breastfeeding in and of itself leads to a little bit of an elevation of bilirubin, but usually not enough to cause a problem. There can also be an A, B, O, which are your blood type, and incompatibility. And the bilirubin level rises here due to hemolysis because of this incompatibility. And we'll usually see this within the first 24 hours after birth. So this kid is pretty yellow. When you really look at him, it's like, boy, that kid's skin is really yellow. And it looks like he has a little bit of a belly button hernia, doesn't it? Looks like a donut. And he's still healing where his umbilicus was, his umbilical cord. So jaundice will occur very mildly and subtle when the level is between 5 and 7. So where you need to look is over a bony prominence. You're going to press the skin and look at the skin color. You can't just look at the skin without touching the kid. As the bilirubin level rises, then we're also going to see that the sclera become yellow. The level for kernicterus to develop is over 20. And then we're going to start seeing these behavior problems also, where the baby no longer wants to eat, they're vomiting, they're hypoactive in their reflexes, and they have poor muscle tone. This is the pathophysiology of the different things that can cause the bili levels to rise. So bruising, it was a traumatic birth. The baby has a cephalhematoma where they accumulate blood between the scalp and the skull. There's some kind of a physiologic destruction of RBCs, which is the typical. This happens after birth. Or they can be a pathological destruction because of ABO incompatibility or possibly Rh incompatibility. So there's hemolysis of the red cells, and then you just follow this down and you can see how the bili levels increase and cause the symptoms. So part of your job is to do a TCB, a transcutaneous bili level on the babies. And so we literally just put it on the skin, we push a button, and it measures a reading. And we like to do 3 readings in a row, and then we're going to come up with the average. Now, I can actually tell what a bilirubin is just by looking at the baby. And it isn't anything that's magic. And I was really glad to see that we have a little schematic of estimating about what the bilirubin level is. And when you see that there's only a little bit of jaundice on the face, that level is about a 6. But if we get all the way down to the lower abdomen, then we're getting down to about a 12. If we get all the way down to almost to the feet, we're looking at a level between 12 and 14. And then if it also affects the feet, then it's going to be over 15. It could be 15, 16, 17, 20. So that's how we can tell. It's nothing magic. This table shows us what the risk is for a baby based on how old they are. And it's from 0 hours old all the way to many hours old. And we will plot this kid once we get the results to know if they're low risk, moderate risk, or high risk. and we use it to decide whether or not this kid needs to be treated. You're going to learn more about that when we are in OB, and every postpartum unit and nursery has a table just like that where we can plot the risk. In fact, I believe the website is billytool.org, something like that, where you can just go online. Once you have your result, you can see where your baby plots out on the graph and then make a decision on if you need to call the pediatrician and say, hey, you know what? This kid is 24 hours old and has already come back with a Billy level of 15, which is extremely high for that age. And we're going to initiate therapy right away. So what do? We do phototherapy. And I have the next slide is going to show you how phototherapy actually works. So the pediatrician will decide if phototherapy is warranted, and anywhere between a level of 10 and 15 milligrams per deciliter will be the decision maker. Some pediatricians are very comfortable with a level of 10 or 11 or 12, and they'll say, go ahead, let the baby go home, but they're going to follow them up in the office the next day. If we have an unreliable mother and father and the baby has a 10, 11, or 12, that baby we may opt to put them under Billy lights just because we don't think they're going to come back to the pediatrician's office the next day. So it's a fluorescent light. Traditionally, it's been a blue light. The newer ones have a white light. When we put them under the Billy lights, they're going to be in an isolette. We have to put eye protection over them, so they're very cute when we put them on the Billy lights. Some of them we even have decorated like their sunglasses. And we're going to expose as much of the skin as possible. So they only have a diaper on. And sometimes we'll even open up the diaper. We'll have the baby laying in the isolette. And if they're laying on their bellies, because we want to have this Billy light on their back as well as on their bellies. Sometimes we'll even put them on a blanket, so they're going to be laying on the Billy blanket, plus they're going to have Billy lights that are coming in from the top. But anyway, we can just take their diaper off and just watch for them to soil the diaper. Monitor the baby for any kind of rashes, and we don't put any kind of lotion on these babies. And we're going to turn them frequently. It would be really cool if we could use some kind of like a rotisserie where we can really rotate the baby. Just kidding. No, we just turn them front, back, front, back. Now, the problem with them going under Billy light is it does limit the amount of time that the parents can bond with the baby because they're not getting any kind of treatment if they're being held by the parent. But when it's time for a feeding, we're going to have the parents come into the nursery and they'll hold the baby then. At Hoag, they do phototherapy right in the room, so at least the baby is with the mother. The other facilities, I don't think they do that. We want to make sure that this baby is hydrated adequately because otherwise it's not going to work that well. We need them to break down the bilirubin and then they're going to pee it out and it's going to come out in their stool. Monitor them for hyperthermia because these are lights, and so that generates its own heat as well as within the isolette. The stools that they're going to have are going to be greened and loose, and it's going to be a little bit bigger volume. In very severe cases, we can do an exchange transfusion. We were talking about this last semester that we cannot remember the last time that we had to do an exchange transfusion. So this is how the light works. They have found that the blue is the most effective in breaking down the bilirubin and turning it into an excretable form. Pretty cool that some engineer discovered that. And this is a baby who's in the isolette. He's on his side. It looks like he's just laying on his diaper and he has his little blindfold on. This is the Billy blanket, and the Omeda Billy blanket can be sent home with the parents to use. You can see how this mother on the bottom left is still putting the Billy blanket on the baby while she's holding him. And this is the results of before and after. So you can see how yellow that baby was and how beautifully pink he is afterwards. And this can happen within 24 hours. And this ends the lecture on hyperbilirubinemia.